Good morning, and thank you for this invitation to speak about endoscopy. And on these slides, we'll try to have like a brief global view of what endoscopy, spine endoscopy is about, and what we have to know, like from basics to start getting into this technique that is not new, but it's getting a lot of trend. I have no disclosures, and that's my where you can contact me. I like that quote because it kind of tells me of a journey as a surgeon that I had, and maybe a lot of us have. Like you try to find new techniques that can help you provide to your patients the best care for the pathology of the spine. And in my case, I tried some trainings to get knowledge in new techniques at that time. So I went to, for example, to make lateral access to Sao Paulo with Dr. Luis Pimenta. Then I tried to do this same technique in complex surgery in San Diego with Dr. Mundis. And then this came up endoscopy and I did it in Germany. I think at the end we all try to find what works for our patients and for us, and we make like a whole. We have a lot of techniques we can use, try to give the best result for the given pathology, and I think endoscopy is just that. It's another tool we can use to help our patients get better from spine pathologies. It has to be very selected cases, as we will see, but as I told you before, it's not a new technique. It has been for a lot of years around. In the early 30s, it was just described by Bormann, the first cases using some direct view of the spine with doing some neuroscopies. Then there was a system developed called Spinoscope by Stern, and Dr. Poole used it to do the same neuroscopy Bormann did before. And those were the first steps a lot of time ago when endoscopy was starting to develop. There were some initial percutaneous attempts by Kambin and Sampson and Hikikata in the early 70s. Posteriorly, as this was getting around the surgeons and more interest was coming forward, in 1988, there was the first report of the use of an endoscope to have direct view of the spine. And then in 1989, it was the first removal of a spine disc with a system that is not endoscopy as we know it, but it's like more arthroscopy lenses and water pumps. But it was like the first case where we had documented the discectomy with direct view. The Right. So in 1990, the first endoscopic system was developed by John, and at the same time, there was also the development of tubular surgery by Casper, and then Foley performed the first tubular discectomy. Then we have an evolution of techniques, as is usually the case. And in this case, in 1996, the Anthony has the first documentation of using two ports, trying to improve the endoscopic techniques at the time. That's the general view of an endoscope. And if you can see in it seems like a tubular form, but it's actually like an oval shape at the end, at the point. And these instruments goes inside a working sleeve. That working sleeve is circular, so we have always space in between the working cannula and the endoscope, and that space helps us to prevent from increases of pressure inside the spinal canal. And it's like a protection system, so you have a lot of pressure inside. Also, if you can see, the big hole in the center of the endoscope is for the instruments to go in, and you have then the camera and the irrigation channel at the periphery. This makes the system work like in a circular fashion. So if you move your endoscope around the working channel, then the camera rotates as well. And you can have different views around the spine once you are inside the spinal cord. Um, we have the working channel at the top next to the endoscope. We have an irrigation inflow channel. Then you have the light cable and the camera head attachment. So this is basically how it works. And one of the most important tools besides the endoscope is the radio frequency. So the radio ablation works with a probe that you can push it and then it turns like a little bands. So you can also move in a circular fashion and get all around the tissue, the view you have at the moment. And that flexibility makes you have a movement freedom, and you can like use it also to palpate and get around the space you are working at. Um, there's different kinds of ablation tools. This one in the picture is one of the most common, and they are getting better and better with time, easier to use. So lately, if you go to any spine convention or even orthopedics or neurosurgery, there's talking about endoscopy, and there's a lot of talks, and there's like they have their own blocks of talks, and you can wonder why, if it's such an old technique that's been described for almost more than 80 years, why is now coming back? Because you can see publications by year are getting increased, and this is stop on the 2020, like this year should be a lot more. And what's happening? Why is it coming back? So I think it's not more like a trend now. It's maybe the natural evolution of spine care. We were a little bit lagged behind other specialties about direct view when we treat pathologies, because you can have like general surgery, you can have like nose, head, and throat surgeries. They all have direct views, and for a lot of time. And we have just started to use it in a big way in our media. Why? Because there's more patient demand, because they know all these techniques in other specialties for less invasive procedures, and we want to provide for them. Also, this technique, compared to the traditional ones, give us like reduced cost and fastest recovery compared with the traditional ones. And this is always something patients look for and we want to provide. Usually, compared to the microscopic procedures, which are right now gold standard, they present a little bit more muscle damage, bone resection, and this one for me is important, the epidural scarring, because when you have direct view, you can be more careful with the neural structures, you can be more careful with the dissection, and that helps a lot with the scarring. Also, incisions are so small that usually if you have to perform a revision, it's like you don't have a lot of scarring. It's like you are operating the patient, let's say like 3 or 4 months after, or 2 weeks, and the surgery is it's just not as hard as it would be with scar tissue. Then microscopic procedures have a little bit more hospital stay and increased need of postoperative analgesics. So I think now the focus in our surgery is to try to minimize the access related injury, and that goes with the muscle damage and the scarring and the bone resection. Because I mean, it happened to me unfortunately once that I did the traditional surgery, and if the bone is like fragile or small, then you can have some facet um, like you can damage the facet and have some instability, and you don't want that to happen. With these kind of techniques, incisions are so small and you are like right on the point where you want to be, then you don't have to do a lot of resection, and the risk of damaging or creating iatrogenic instability is not as easy as the other one. So you can prevent that. And sometimes you can give a lot of time to that patient without fusion, because you can make that disc keep working for a little bit more. There's a lot of documentation that compare both techniques, like microscopic and endoscopy, for different pathologies. Like the most studied one, obviously, is lumbar disc herniations, but you have descriptions of how they compare in lumbar stenosis, cervical cases, and you can see there's a little bit more advantage in endoscopic. It's not huge at the long term, because we can have patients usually present with the same real outcome, patient-based outcome, that with both techniques. But once you get familiarized with the technique, you can see that your life could be easier when you try to do this kind of surgery. Like, for example, in this image, we can see how the view is so different with microscope or sorry, microscopic surgery, and how the different view of full endoscopy surgery. Why is that? Because with microscopic surgery, you have the view with blood, you have the view with the coagulation, and you have a lot of bleeding. With full endoscopy, the key is the water irrigation, that you can get a lot of it helps you to get some pressure in the bleeding, like try to stop the bleeding because of water pressure. And also it gives you a little bit of help with the dissection and view of the different structures that you are working in. Also, if microscopy is a little bit less freedom of movement once you are inside the spinal canal. You can't move around like you can do it with endoscopy, because with endoscopy you have the eye position close to the pathology, and you have that circular fashion to move around inside, that gives you a lot of like 360 view right up the spot you are looking at. Uh, it's different with microscopy, because you have to see all from above, and the view is a little bit a lot different in movement, in freedom of movement, and trying to work around the space. So in comparison, you can have, as the most important advantage, less soft tissue trauma, reduced blood loss, decreased damage to the epidural blood supply, and then less scarring and fibrosis, shorter hospital stays, and shorter time to return to work. Sometimes you have to take this into account. The shorter hospital stays may be not as real, because I mean, we have the problems with insurance companies that, for example, here in Mexico, they have to stay for, let's say, 24 hours, so they can then use their insurance and get the procedure covered. And I've heard in some other countries they have some similar problems. So hospital stay is not as reported as it should, because if I could, I will do these endoscopies like in an outpatient basis, so they wouldn't need to stay in the hospital. But I can't because of insurance cover. But I think that problem should take into account when you are reading a paper. But I think in my experience is faster, the recovery. They need less hospital stay, less painkillers, and they can return to work faster as well. And what we were talking about irrigation advantage, it helps you a lot to create that hemostatic effect. And last year in the our spine meeting, there was like this big series of cases. And at the end, they concluded that the advantage long-term of microscopic versus endoscopy was not as real in numbers as it was in what we believe at that time. But in one slide, there was like this comparison of infections, and microscopic cases had, of the 300 cases, there was 4 infections, and endoscopy had no infections at all. So I think for those four patients that had the infection, they would prefer, and also the surgeons would prefer have zero infections. So the advantage of having no infections or a super low risk of infection, I think it's one big point trying to do this procedure when it's well indicated. And we have different systems. We have the full endoscopy, which is like the endoscope I showed you. It's everything is done by one single working channel, the view and the instrument use. And then we have the biportal endoscopy, in which you have independent use of the camera and the instruments. So you have more movement. And you also have the microendoscopy. This one I just put it there because it exists, but it's really it's like a blending between the tubular and the endoscopy, because you have a big working channel that is fixated and you can use both hands to work. You don't have water inflow because it's such a big hole, so you have like a microscopic view, but you have a little bit of endoscopy movement and freedom, and it's like a blending. Right there, you can see the size of the working channel of the microendoscopy compared to the full endoscopy and biportal. Um, Full endoscopy is or uniportal is using the single working channel to move the camera and use the instruments. So that's why it's a little bit hard to when you are getting used to this technique, because you have to learn how to move independently in the same spot, the camera, the instruments, and the working sleeve. So that gives you in general, compared with the biportal, less motion in the distal end of the instruments, but the advantage is only one entry point, so you have less collateral tissue damage. And since it's such a small working space, you have also a limitation in the device implantation. There are now new cages that are expandable and you can use through these working channels. So technology is getting there, but it's not as easy as microscopic. And biportal, then as we saw in the picture, you have two working channels, one for the endoscope, the camera, and the other for the instruments. And also you have the independence use of the scope and that control that gives you more degree of freedom. So this is easier for all those surgeons that come with arthroscopic background to get used to, because you have the same techniques of triangulation, and you can and you feel more comfortable usually by using this biportal endoscopy. The difference between as I feel it is that with arthroscopy you are in a restrained space. You are inside an articulation, and in here the point where you have to be it's a lot smaller than, let's say, a knee or a hip, and you have more freedom because you don't have any constraint around. So it's good to have a greater degree of freedom, but it's also a little bit riskier because you can be in the wrong space. So you have to be really controlling that. You use multiple access portals, so you have more tissue damage. It's not a lot usually, but it's more than the only portal. And you have also, because it's a small space, limited ability to implant devices. And micro endoscopy is the one we saw, the big one, tubular one. You have the single working channel with multiple instruments you can be used at the same time. And you have your, as a surgeon, your hands free because the working channel is fixed to the table. But at the same time, you don't have the advantage of the water irrigation, and you don't have the advantage of less tissue damage, and it behaves a little bit more like the tubular surgery. So with this, with endoscopy, we can treat everything in the spine, like from cervical, thoracic, and lumbar. Not every pathology, but we can work in every anatomy of the spine. And there's increasing literature and papers that try to demonstrate advantage by using these techniques in different pathologies around the whole spine. But at the end, what we have to look for when we decide to use this technique, and then we have to decide the approach, is try to use the easier and the most effective for that particular case, so you can have a better success rate. Because some of the problems that present when you start making working with this technique is that there's the learning curve, as we will see later, is big. So you have to have good knowledge, good training, and then good case and good decision in what approach and what technique to use. You already think about spine endoscopy surgery. So we have different approaches. The most common one, it's transforaminal and interlaminar. Um, Interlaminar is the easiest one to get used to as anatomically speaking, because it's just like open surgery or microscopic surgery. It's the same view. And transforaminal is a different anatomy. It goes through the Cambin triangle, and you have to make a few cases or a lot of training to get used to the anatomy. But once you have the knowledge of the anatomy, it's easier to do the transforaminal than the interlaminar. And transforaminal can also be divided in different ways to try to perform, because you can go extraforaminal, foraminal, or you can just go in the middle. And basically, these approaches should be used. A surgeon should just be used to a surgeon should be used to both approaches, so you can treat all the pathologies, and you can have at the case you are working with, you can have the best alternative or the best choice in how to approach that pathology. Both approaches are good, but are for different kind of in this case, for example, herniations. But they are techniques that work when they are well applied. So the interlaminar technique, it's the newest one. Transforaminal was the first one to be described. Interlaminar was described in 2006, and incision is like in the picture, paramedial, closer to the spinous process, and it has the broadest of application because you have a lot of movement, but it's mostly used in intracanal herniations. It's also used in migrated calcified herniations, and also is used in cervical spine in foraminal stenosis or soft disc, and in thoracic spine is good for hypertrophic flavum or ossified. And as you can see in that picture, there's a lot of like that endoscope is free down there, so it has a lot of movement. So that's the thing that's hard to kind of control. And transforaminal, it was the first one described used through the Cambin triangle. And you have in here you have, when you use it, it's a limited capacity to address all the lateral recess or central stenosis issues, because it's hard to treat all the, or have a better view of all the facets and the flavum. And in this technique, it's easier if you see there. If you are in the transforaminal approach, you can have more control of the endoscope because it's a little bit more fixated than the interlaminar. So that's why this one is easier to get used to, because there's not a lot of movement around. I mean, you can have a lot of movement if you go extraforaminal, because you won't be like anchored into any structure. But if you use the technique that's inside out, that's the first one described, then you are anchored to the disc and then to the foramen. Contrary to the outside in which at the first you are outside the foramen, so you're a little bit in the earth, like saying in the earth, you have a lot of movement, and then you go in the foramen. So usually in this outside in technique, the technique describes you have to do like foraminoplasty. You have to open the space with fluoroscopy with a rim, and then you can put the endoscope inside. There's the other one that goes half. It's called half and half. In this one, you try to stay in the posterolateral annulus, because inside out you go to the disc, outside you go outside it you go outside the foramen, and half you go to the disc, to the annulus, and then you can move inside or outside. So this one is the one I prefer the most. You can see a graphic description here. So inside out, as you can see, the endoscope is in the disc, and then you can try to get fragments inside or a little bit that goes through the annulus. The outside in, you can see in the picture, the facet is trimmed, it's a little bit cut, and that's so you can start by maybe if you have like extraforaminal herniation, that's easier on that technique. You can start there and then moving inside. And then you have the half and half, which you stay in the annulus and you go inside or outside. So you have like that choice. But this, let's remember, this has to be chosen when you already have your case decided, and you have to know this beforehand, uh, because you have to choose depending on the location of the herniation in this case, and that will be the whole key point and the success of your surgery. That's the that's how you mark your patient with the fluoroscopy, and the skin and the marks. The green line is the tip of the spinous process. The red line is the like the sealing of the facets, and that's where you have to try to get into the lateral space of the disc, based on your epiline, which marks the disc space. And that's like the anatomic view once you're inside. The crosses on the lower part of the picture is the disc. The three arrows, they are marking a transverse ligament, and the big arrow is marking the epidural space. So this transforaminal approach is best for foraminal and extraforaminal lumbar disc herniations and foraminal stenosis. You can use it once you are used to for some paracentral central low migrate herniations. And I think it's good for thoracic spine as well, a lot of pathologies. And upper lumbar is safer because foramen is big and the interlaminar space is not. It's a little bit small, and you have to do a lot of bone resection. So this one is actually a good technique for upper lumbar. So as we talked before, we can use for lumbar disc herniations. This is the most studied case pathology for the application of spine endoscopy. And we have the advantage we talked before: shorter operative times, lower use of postoperative pain medication, and the shorter return to work, which is very important. And I think at first maybe the shorter operative time is not as it is there described. This is a paper by Rutten in, I think it was 2009. And once you get used to the technique, you can get to those times. You can use it for lumbar spinal stenosis, and for me, this has been a practice changer in my office, because I can treat patients that otherwise I wouldn't be like in. I wouldn't offer a surgical approach. For example, old patient, more than 80 years, with chronic renal failure, with he had like a heart disease, and he needed um are you there, Don? So for example, I had this patient, 80 years old, chronic renal failure. He was dependent on pacemaker 100% because of heart issue. He couldn't walk. He could walk like 5 minutes or 3 blocks, and then he had to stop. And he was having already some venous thrombosis and different problems. He also had Parkinson's. So he's a patient that I wouldn't offer open surgery for spinal decompression, but I did an endoscopy, and he did really well. Like, he started walking a lot. I mean, he started to have a better sleep, because he had to wake up at night to go to the bathroom like 6 times through night. Then he improved to only waking up once. So patients like this, as population gets older, I think we'll have more application for endoscopy for spinal stenosis, and we'll have better results than the open technique. So for me, this is a big point where endoscopy is over the microscopic techniques. And the places where we have a lot of papers is Asia, especially Korea. So there's a lot of papers from there, and all of them demonstrate that spinal stenosis can be treated by endoscopy with better results than with laminectomy. And they use a lot the biportal system. I think with biportal, you can actually, in cases of stenosis, go faster and maybe do it in less time with the same result that uniportal. In the United States, we have some papers too, and also we have more evidence that they do better than the open surgery. The only thing that was different is that more it was longer the surgical time, but I mean, I think that depends on the center where the paper was made. There's some reports of lumbar spondylolisthesis. So in this case, it has to be a stable spondylolisthesis because the point will be to decompress and to take herniation out and try to make space for the compression that's in that case. Unstable spondylolisthesis, not recommended. The same as adjacent segment disease. It's also for pathology that are stable. Unstable adjacent segment disease should be treated with fusion, but the stable cases could be helped with endoscopy decompression, and it will make a lot of difference for those patients. And in cervical discectomy and foraminotomy, you can use the endoscopy as well. There's a lot of publications, Germany and Norway mainly, where you can see results that getting more evidence and results that endoscopy performs better at the end than the ACDF. But one thing that's important to mention, a lot of these papers, when you go back to the patient report outcome at the end to follow up, there's not a lot of difference. So it's only like at the first steps, a hospital stay, the surgery time, and painkiller use. And also there's new cases of cervical laminotomy compared to the traditional laminoplasty. We also have evidence of good results. So one of the things we have to take into account is the learning curve. So it's actually a steeper and more difficult learning curve than when you are getting used to all new techniques in the spine. As we said before, the transforaminal it's difficult to understand at first, but once you get it, it's easier to master. And the interlaminar is easier to understand, but it's more difficult to master. But the use of interlaminar, it's a lot bigger than for transforaminal, so you have to get used to both. And I think the most important thing is that you have to prevent complications because of the learning curve. So at first, the recommendations are to have a proper training, to have a very good case selection, so you have which approach to use. Really, you need to understand that before going into surgery. And this is only made with extensive training and supervision during initial cases. Usually the first 30 surgeries, you need supervision because, you don't need it, but it will be safer to have it. And they told me in my training, try to start always with L5S1 cases because that's the easier. You have the biggest window, and it's you have a lot of movement. Structures are well delimited, so it's usually the best case scenario when you're studying this is going through L5S1 with supervision for the first cases, and you need a lot of training. But once you're over the curve, results are great. And one thing we have to take into account also is that we don't most of these papers, Korea and Germany and the US, are made from centers that are really good at this technique. Like they are high level centers for spine endoscopy. For example, the papers published by Dr. Rutten and in that hospital, Santana Hospital, surgeons there have like they have like 7 cases to 8 cases every day. So the volume is huge. And one thing we have to try to comprehend is how can if we can translate these findings of these papers to the general practice. I think can be done, but there will be definitely a difference. But we can get to those same results once we have mastered the learning curve. I think that's the most important thing, to have that over, and then you can safely apply these approaches and these techniques and have the same results as those big centers that publish have. And the other thing we need is the support from the companies. So I think like right now this technique is getting a lot of importance in meetings. So companies are getting to it, and I think it will happen. We will have growth, and we will have new tools to get this better. And definitely it's something I think we should all, as spine surgeons, try to master, have in our tool box to use when a given patient is presented to us. And there's some review articles, reference articles for used in this presentation. Thank you.